This training, Prescribing Pasteurized Donor Human Milk, PDHM, a provider's guide to safe and effective use, is brought to you by the North Carolina Health and Human Services Division of Public Health, Community and Clinical Connections for Prevention and Health Branch, and the WakeMed Mothers Milk Bank of Cary, North Carolina. Welcome, and today we will explore the clinical, logistical, and regulatory elements of prescribing pasteurized donor human milk for infants in both hospital and outpatient settings. Access to pasteurized donor human milk, PDHM, is a critical component of infant nutrition and health, particularly for medically vulnerable infants. The North Carolina Department of Health and Human Services recognizes that systemic barriers, including financial constraints, geographic limitations, and healthcare inequities, can impact a family's ability to access this essential resource. The North Carolina Department of Health and Human Services' commitment to population health means working to ensure that all infants, regardless of race, socioeconomic status, or geographic location, have equitable access to pasteurized donor human milk when medically necessary. This includes expanding donor milk distribution sites and providing culturally responsive education to families and healthcare providers. We strive to remove barriers that disproportionately affect historically marginalized communities by partnering with community organizations, expanding donor recruitment efforts, and addressing disparities in breastfeeding support. The North Carolina Department of Health and Human Services believes that pasteurized donor human milk should be available as a temporary and life-saving intervention for infants who need it, while also ensuring families receive comprehensive lactation support to establish and sustain their own milk supply whenever possible. By centering equity and inclusion in our work, we aim to create a healthcare system where all families have the support and resources necessary to provide their infants with the best possible start in life. By the end of this training, you'll be equipped to prescribe pasteurized donor human milk appropriately, with a clear understanding of when, why, and how to do so. Pasteurized donor human milk is donated human milk that has been rigorously screened, pasteurized, and tested to ensure safety. It's often provided by nonprofit banks following the Human Milk Banking Association of North America, or HIMBANA, guidelines. Pasteurized donor human milk offers a range of important benefits for infants, particularly those who are premature or medically fragile. Donor milk provides essential nutrients, enzymes, and immunological components, like antibodies, that support healthy growth and development. Studies show that preterm infants fed donor milk are less likely to develop necrotizing enterocolitis compared with those fed formula. Donor milk is generally easier to digest than formula, which can help reduce gastrointestinal issues such as constipation, gas, and feeding intolerance. Even after pasteurization, pasteurized donor human milk retains some immune factors that help protect infants from infections. Using donor milk can help parents continue exclusive breastfeeding by bridging the gap until milk supply is sufficient. Donor milk provides a human milk option for infants who cannot receive their parents' milk, offering improved health outcomes compared with formula. And a robust tracking system ensures every batch of donor milk can be traced from donor to recipient. This allows for rapid response in the rare event of contamination, enhances safety monitoring, and ensures accountability throughout the supply chain. While donor milk is generally safe and beneficial, there are some limitations to consider. Pasteurization kills harmful bacteria but also reduces some of the milk's beneficial enzymes, hormones, and immunological components. Milk composition varies between donors and may not fully meet the caloric or nutrient needs of very premature infants without fortification. Donor milk is typically more expensive than formula and may not be available to all families, particularly for outpatient or home use. Although donor milk is screened and pasteurized, trace contaminants or allergens could theoretically remain. And finally, demand often exceeds supply, so donor milk may not always be available for every infant who needs it. As of August 2025, there are 29 HIMBANA-accredited milk banks across 25 states in the U.S. In North Carolina, the WakeMed Mothers Milk Bank in Cary is the state's only HIMBANA-accredited milk bank. It is responsible for donor screening, milk collection, testing, pasteurization of donor milk, and the distribution of pasteurized donor human milk to hospitals and distribution centers. Potential milk donors undergo a thorough screening process to ensure the safety of the milk. First, donors complete phone and written interviews where their medical history, lifestyle, and safe milk handling and storage are carefully assessed. Next, if a donor is a bereaved mother, approval from their OB/GYN is needed. For all other donors, only their physician's approval and assigned medical release are required. Finally, donors undergo blood testing, provided at no cost. The tests screen for hepatitis B and C, HIV, HTLV, the human T-cell lymphotropic virus, and syphilis. Only those with negative results for all these infections are approved to donate to WakeMed. Once the milk is donated, it goes through a rigorous processing system to ensure safety and quality. First, a sample from each donation is sent to the lab for initial testing for viruses, bacteria, specifically bacillus, and drug contamination. Next, pooling occurs where thawed milk from multiple donors is combined. Then, the milk is homogenized, ensuring an even distribution of fat throughout. The milk is then pasteurized using Holder pasteurization, where it is heated to 62.5 degrees Celsius, then held at temperature for 30 minutes, eliminating any harmful bacteria or viruses. Finally, post-pasteurization testing is conducted on another sample to confirm that no potentially harmful pathogens remain. Please note that WakeMed Mothers Milk Bank does not fulfill individual prescriptions for donor milk. This is done exclusively through designated distribution centers. Despite its many benefits, donor milk is a limited resource. Unlike formula, which can be mass-produced, donor milk depends on the generosity of lactating parents who donate their extra milk. These donors are not compensated for any milk received by the WakeMed Mothers Milk Bank. As mentioned previously, this donor milk undergoes careful screening and processing to ensure safety, which adds to its scarcity. To ensure fair distribution, we follow a strict allocation system based on medical need. The priority for WakeMed Mothers Milk Bank is to ensure donor milk reaches the most vulnerable infants first. Premature and medically fragile infants in hospital NICUs receive top priority. Next is inpatient supplementation and bridge bags for families experiencing delayed milk production, maternal illness, or latch difficulties. Bridge bags are typically 500 milliliters of pasteurized donor human milk that are sent home with families to help bridge the time between birth and the development of the mother's milk supply. And last are outpatient community prescriptions. For full-term or late preterm infants, this is available only when medically indicated and as a short-term bridge to breastfeeding. The allocation of donor milk is dictated by the Human Milk Banking Association of North America and depends on the available donor milk supply. If the donor milk supply decreases, outpatient distribution would be the first area affected. Families should be aware that donor milk is intended as a short-term support rather than a long-term feeding solution. Due to the limited supply, ongoing supplementation with donor milk is not sustainable. For infants requiring extended supplementation, formula may be the recommended alternative at this time. The American Academy of Pediatrics recommends pasteurized donor human milk when mother's milk is unavailable, especially for high-risk infants. It helps reduce risk for necrotizing enterocolitis and supports immune function. The following are groups who may benefit from pasteurized donor human milk. Medically fragile infants in the NICU. These are infants who may be born preterm or small for their gestational age, have a low birth weight, experience feeding intolerance or gastrointestinal issues, or are at risk from necrotizing enterocolitis. Infants with hypoglycemia or jaundice. These babies may require supplementation to stabilize blood sugar levels or to support increased hydration during treatment. Full-term infants with temporary feeding challenges. This includes infants who experience excessive early weight loss, typically more than 7 to 10% postpartum, show signs of inadequate intake or dehydration, or whose mothers have delayed lactogenesis or low milk supply in the first 1 to 2 weeks after birth. And lastly, infants whose parents are temporarily unable to provide expressed breast milk. This may occur when parents are not yet producing milk in the early postpartum period, or when maternal illness, medication use, or hospitalization prevents direct breastfeeding or milk expression. Latch or feeding difficulties are another reason for supplementation. When a baby struggles to breastfeed effectively, supplementation can help maintain adequate nutrition while the family seeks care from a lactation specialist. When lactating families receive effective, personalized support, they are more likely to breastfeed for longer, improving overall breastfeeding duration rates. Pasteurized donor human milk is meant to be a supplement for short-term use. If infants need long-term nutritional support, a high-calorie formula may be a better option. Here we highlight the key criteria for a prescription for donor milk use in outpatient settings. First, the patient should be evaluated within 2 weeks of birth or hospital discharge. This early period is critical for supporting newborn nutrition, especially when breastfeeding challenges arise. Next, to qualify for a prescription for pasteurized donor human milk, the parent should not have stored, pumped breast milk available. When a parent has stored their own milk, it should be used for supplementation before considering donor milk. However, if the parent is not storing breast milk, donor milk can provide essential nutrition while they work on establishing or increasing their own milk supply. Finally, supplementation should be based on a clear medical need, with the expectation that donor milk will be used only for a limited time. This approach helps ensure donor milk is reserved for infants during critical periods of need. Because long-term use of donor milk is not sustainable, formula is recommended for infants requiring extended supplementation. Together, these criteria help guide when donor milk is appropriate and ensure that it's prioritized for infants with the greatest medical need during that early vulnerable stage. In North Carolina, pasteurized donor human milk is intended as a short-term bridge during the early postpartum period, typically within 2 weeks of birth or hospital discharge. This guidance ensures donor milk is used safely, appropriately, and equitably. Here's why. This supports the early establishment of lactation. The first 2 weeks postpartum are critical for stimulating and building milk supply. If milk is delayed due to birth complications, cesarean section, or maternal health conditions, pasteurized donor human milk can provide temporary nutritional support while protecting the infant's gut microbiome. During this time, close follow-up and lactation support often allow families to transition to exclusive breastfeeding without long-term supplementation. 2. Pasteurized donor human milk is a limited resource. Donor milk is a precious, finite resource prioritized for medically fragile infants and short-term use. Restricting prescriptions to the early period helps ensure that donor milk remains available for those in critical need, such as NICU babies or newborns with early feeding complications. 3. Low milk supply in later stages can often be improved with support. During growth spurts, babies naturally feed more frequently, which can lead some parents to mistakenly believe their milk supply is insufficient. However, this increased demand is a normal part of helping the body adjust and produce more milk. It's essential during these times to increase breastfeeding frequency to support supply development. Introducing supplementation with donor milk at this stage may interfere with that process by reducing time at the breast, potentially leading to a further decrease in milk production. True supply issues beyond the early weeks are often tied to infrequent or ineffective breastfeeding, lack of milk removal, like not pumping or nursing often enough, or supplementing without addressing supply directly. Supplementing during this stage can reduce the baby's time at the breast, which in turn sends weaker signals to the body to produce more milk. In these cases, we recommend encouraging access to a lactation consultant or trained breastfeeding professional to assess, coach, and support the parent-baby dyad during periods of low supply. 4. Supplementing can hinder ongoing supply development. Breast milk production follows a supply and demand model. The more milk that is removed, the more the body produces. Supplementing with either donor milk or formula beyond the newborn period without addressing milk removal can undermine lactation, leading to further reductions in supply. Instead of supplementing, providers should focus on frequent breastfeeding or pumping, referrals to lactation support, and addressing underlying causes of perceived or actual low supply. Recommendations are as follows. Use pasteurized donor human milk within the first 2 weeks to provide short-term, medically necessary support, along with referrals to lactation support. Avoid routine use of pasteurized donor human milk after this window, as long-term supplementation can interfere with the development of a full milk supply. Pasteurized donor human milk is intended to support a parent's milk supply, not replace it. And finally, refer families to lactation consultants early and often to support successful breastfeeding and avoid unnecessary supplementation. To the left is a blank pasteurized donor human milk medical prescription form. Scan the QR code to access a copy of the prescription form to download and print. The download also includes an educational handout for parents called Using Pasteurized Donor Human Milk Without Hindering Your Own Milk Supply. This resource walks families through the steps of how to safely and effectively use pasteurized donor human milk. In North Carolina, prescriptions are required for outpatient use of pasteurized donor human milk. Dispensing practices of pasteurized donor human milk vary. The WakeMed Mothers Milk Bank does not dispense donor milk directly to patients. Your patients will need to find a designated distribution center to fill their prescription. You can find the list of designated distribution centers on WakeMed's website at this web address, or by scanning the QR code here. Electronic prescriptions are accepted. Donor milk is currently not covered by Medicaid or private insurance in North Carolina. Families may need financial support. Prices will vary depending on the distribution center, and they may have a sliding pricing scale based on income. You may reach out to your local distribution center to find out prices, procedures, and availability. If you are prescribing pasteurized donor human milk and referring the family to a distribution center that offers integrated lactation support, you do not need to determine the specific amount of donor milk. A lactation specialist will assess the infant's feeding needs and establish the appropriate volume based on that evaluation. However, if you are prescribing pasteurized donor human milk to be filled at a pharmacy, such as 501 Pharmacy, lactation support must be arranged separately, and you will need to calculate the amount of donor milk to be dispensed. During the first 2 weeks postpartum, general supplementation guidelines for infants aged 42 to 44 weeks corrected gestational age are: supplement 15 to 30 milliliters or 0.5 to 1 ounce of donor milk after breastfeeding, as needed. Daily total: 150 to 300 milliliters or 5 to 10 ounces of donor milk per day. Weekly total: 1,050 to 2,100 milliliters, or 35 to 70 ounces of donor milk per infant. These amounts are intended to supplement maternal milk, not replace it, and are designed to support infants' nutritional needs during the early postpartum period. There are many factors that should be considered when calculating infant needs and is patient-dependent. Please use your clinical judgment. Due to the limited supply of pasteurized donor human milk, refills are restricted to ensure equitable distribution to infants who need it most. At the follow-up visit, families may receive up to 1 week's worth of donor milk, provided they continue to meet eligibility criteria. Providers and lactation specialists should work closely with families to develop a personalized weaning plan that supports a smooth transition from donor milk to the mother's own milk, which remains the optimal source of nutrition for infants. Encouraging frequent breastfeeding, optimizing milk production, and providing tailored lactation support can help families achieve this transition as soon as possible. If families continue to experience challenges with milk production, latch, or any other breastfeeding concerns, lactation specialists should refer them to a breastfeeding medicine specialist for further evaluation and support. Early intervention and specialized care can help address underlying issues and promote long-term breastfeeding success. This diagram outlines the step-by-step process for prescribing pasteurized donor human milk. You'll begin by assessing your patient. If they meet the eligibility criteria, within 2 weeks of delivery or hospital discharge, showing signs of low milk supply, and likely to benefit from short-term supplementation, you may move forward with a pasteurized donor human milk prescription and a referral for lactation support. There are 2 main pathways depending on local resources. If your area has an outpatient lactation care center that also serves as a donor milk distribution center, you can write the prescription and refer the patient to that center. The lactation team will complete the assessment, determine the quantity of donor milk needed, and dispense the milk directly. If no such center exists nearby, you will need to calculate the donor milk volume based on feeding guidelines. Write the prescription. Guide the family on where to fill it, such as a participating pharmacy, and refer separately to a lactation care provider. In either case, the goal is to ensure the patient receives both pasteurized donor milk for temporary lactation support and skilled lactation care to build their own milk supply. Let's discuss some quick case studies. This first one is around delayed lactogenesis due to complications during delivery. Here is the background. Baby Liam was born at 36 weeks gestation, weighing 5 pounds 8 ounces. His mother, Sarah, experienced delayed lactogenesis due to delivery complications. To support Liam's early nutritional needs, temporary supplementation was medically indicated. At his 4-day follow-up visit, Liam weighed 5 pounds 2 ounces, a 7% loss from birth weight, which warrants close monitoring given his prematurity and feeding challenges. During the visit, Sarah reported breastfeeding 8 to 10 times daily, though Liam showed signs of frustration at the breast and had long, inefficient feeding sessions. Sarah was producing only small amounts of colostrum, with minimal transitional milk beginning to appear. At this point, you may want to pause and reflect on how you would develop a personalized care plan for baby Liam and Sarah. What immediate goals would you set, and which support services or resources would you involve to meet their needs? Recognizing the medical need for short-term supplementation and the family's commitment to breastfeeding, Liam's pediatrician prescribed pasteurized donor human milk as a bridge, while Sarah worked to establish her milk supply. The prescription was paired with a referral to a lactation consultant for targeted support. The plan of care included supporting Sarah with lactation strategies such as breast massage, frequent skin-to-skin contact, and pumping after feeds, monitoring Liam's weight and feeding efficiency closely over the next several days, developing a transition plan in coordination with the lactation consultant to taper pasteurized donor human milk as Sarah's milk supply increased. By the 3rd follow-up with the lactation consultant, Sarah's milk supply had significantly improved. Liam was thriving, now weighing 6 pounds 2 ounces and showing healthy, consistent weight gain. Sarah felt confident in her ability to continue breastfeeding independently, and no further supplementation was needed. Here are the key takeaways for this case. Pasteurized donor human milk can provide safe, effective, short-term supplementation for infants experiencing early feeding challenges when maternal milk supply is delayed. Frequent follow-up visits with the lactation consultant allow for real-time adjustments in supplementation volume and duration, ensuring donor milk is used appropriately. Lactation support is essential throughout the process, helping parents boost milk supply and navigate the emotional and physical aspects of breastfeeding. Providers should emphasize that pasteurized donor human milk is a temporary tool, best used in tandem with strategies to establish and increase maternal milk production. Baby Liam's story illustrates how providers play a vital role in coordinating care, guiding clinical decisions, and supporting families through early feeding challenges with evidence-based strategies. This case study discusses a full-term infant with weight loss due to delayed milk supply. Here is the background. Baby Noah was born at 39 weeks gestation via an uncomplicated vaginal delivery. However, his mother Jessica experienced a significant postpartum hemorrhage, which can contribute to delayed lactogenesis. Jessica was highly motivated to breastfeed, and Noah latched well in the hospital. At his 4-day pediatric visit, however, he had lost 11% of his birth weight. dropping from 7 pounds 8 ounces to 6 pounds 13 ounces. This places him above the 95th percentile for weight loss on the NEWT, Newborn Weight Tool chart, and raises concern for inadequate intake. Jessica reported that Noah was nursing frequently, 10 to 12 times per day, but remained fussy and showed hunger cues shortly after feedings, while she was producing small amounts of colostrum. Her milk had not yet fully transitioned, and Noah was not receiving enough to support his needs. At this point, feel free to pause and consider how you might build a personalized care plan for baby Noah and Jessica. What would your short-term goals be? What support systems would you engage? Noah's pediatrician recognized a medical indication for short-term supplementation. To preserve Jessica's breastfeeding goals and provide optimal nutrition, the pediatrician prescribed pasteurized donor human milk and referred her to a lactation consultant for immediate support. Jessica expressed concern that supplementing, even temporarily, might interfere with her ability to exclusively breastfeed. The pediatrician reassured her that pasteurized donor human milk would serve as a bridge, not a barrier, and emphasized that supplementing with donor milk, paired with skilled lactation support, could actually protect and extend the breastfeeding relationship. The plan of care included prescribing pasteurized donor human milk for short-term supplementation, with close weight monitoring, a same-day referral to a lactation consultant to support latch, assess transfer, and implement milk supply strategies, like hand expression, pumping, or skin-to-skin techniques. And lastly, a collaborative transition plan to reduce supplementation as Jessica's milk volume increased. 3 days after initiating pasteurized donor human milk, baby Noah returned to his pediatrician for an in-person weight check. The results were promptly shared with the lactation consultant to ensure continuity of care. This was followed by a virtual lactation follow-up, during which Jessica's milk supply and Noah's feeding behaviors were reassessed. The coordinated care team, pediatrician, and lactation consultant worked toward a shared goal, gradually reducing donor milk as Jessica's supply increased. Let's discuss the key progress milestones. By day 7, Noah had gained 5 ounces and was showing clear signs of improved milk intake, like shorter, more efficient feeds and less fussiness. Jessica's milk supply began to increase with consistent breastfeeding, pumping, and lactation support. By day 10, Jessica was producing enough milk to meet Noah's full nutritional needs, and donor milk was no longer needed. At the 2-week pediatric visit, Noah weighed 7 pounds 9 ounces, surpassing his birth weight. Jessica had successfully transitioned to exclusive breastfeeding, and both she and Noah were thriving. Clinical takeaways for providers. Pasteurized donor human milk can serve as a vital short-term bridge for infants experiencing feeding challenges or delayed milk supply. Close collaboration with lactation professionals supports successful transitions and addresses parental concerns early. Frequent weight monitoring helps evaluate the effectiveness of supplementation and guides appropriate tapering. Framing supplementation as part of the care plan, not a failure, builds trust and confidence in the breastfeeding process. Jessica and Noah's journey demonstrates how timely intervention, thoughtful planning, and emotional support, anchored by pediatric guidance, can protect both infant health and breastfeeding success. This case study discusses a case where donor milk is not the solution. Here is the background. A first-time mother delivered a full-term, healthy infant and intended to exclusively breastfeed. However, at 5 days postpartum, despite frequent nursing, mother had no breast engorgement. The baby remained unsatisfied after feeds and exhibited persistent hunger cues. Additionally, the mother had no breast changes during pregnancy. At the pediatric follow-up, the baby had not regained sufficient weight, prompting concern about caloric intake and hydration. Based on clinical assessment, the pediatrician recommended temporary supplementation with pasteurized donor human milk and referred the mother for lactation support to address the delayed lactogenesis. This approach provided the infant with necessary nutrition while protecting gut integrity and supporting the mother's long-term breastfeeding goals. Pause here if you'd like time to develop a care plan for this patient. Consider how you might guide supplementation, lactation follow-up, and communication with the family. To ensure the infant's nutritional needs were met, the pediatrician prescribed pasteurized donor human milk as a short-term supplement, while encouraging the mother to continue breastfeeding. This approach supported the infant's growth without disrupting the breastfeeding relationship. The mother was referred to a lactation consultant for comprehensive evaluation and guidance. The lactation consultant provided hands-on strategies to improve latch, increase stimulation, and support milk production. Despite consistent breastfeeding and diligent follow-through, the milk supply did not improve, and the mother continued to show no physiological signs of lactation. Recognizing the possibility of an underlying medical condition, the lactation consultant collaborated with the pediatrician to refer the mother to a breastfeeding medicine specialist for further evaluation and support. After a comprehensive assessment, the breastfeeding medicine specialist diagnosed the mother with an underlying medical condition that prevented sufficient milk production. Given this diagnosis, the pediatrician and care team worked together to transition the infant from pasteurized donor human milk to infant formula, creating a sustainable, long-term nutrition plan. The pediatrician provided the mother with education on appropriate formula selection, safe preparation, and responsive feeding techniques to ensure the baby continued to thrive. While pasteurized donor human milk served as an effective short-term bridge, this case highlights that it is not a universal solution. Some clinical scenarios, like maternal glandular insufficiency or hormonal disorders, require individualized approaches to infant feeding. This case underscores the pediatrician's role in delivering compassionate, tailored care by coordinating skilled lactation and medical support, guiding families through transitions based on medical realities, and ensuring infants receive adequate nutrition at every stage. By understanding the whole clinical picture, pediatricians can empower families with the tools, knowledge, and the support they need to move forward confidently. Whether that path leads to exclusive breastfeeding, combination feeding, or formula use. Thank you for watching the North Carolina Human Donor Milk Distribution Center training, ensuring the safe and effective use of pasteurized donor human milk. Here are some key takeaways. Pasteurized donor human milk provides critical health benefits but is a limited resource. Distribution must follow strict guidelines. Families may need education on using donor milk without hindering their own milk supply, feeding techniques, and donor milk storage. Donor milk should be a time-limited support with the goal of transitioning to exclusive breastfeeding. And finally, follow-ups are essential for tracking progress and ensuring appropriate use. We appreciate your time and commitment in completing this training. To receive credit, simply scan the QR code and complete the form. We invite you to review these resources and use the QR code to access the citations. The North Carolina Human Donor Milk Distribution Center training, ensuring safe and effective use of pasteurized donor human milk, was brought to you by the North Carolina Health and Human Services, Division of Public Health, Community and Clinical Connections for Prevention and Health Branch, and the WakeMed Mothers Milk Bank of Cary, North Carolina. Thank you for your dedication to supporting mothers and babies across North Carolina.